هيبوكرات تكون هي اللينك بين أطبائنا اللي موجودين خارج العراق والأطباء داخل العراق. وكانت نشكر الدكتور أحمد على المبادرة مالته أن تكون داخل المستشفى لتفيد أكثر عدد ممكن من الدكاترة الموجودين والنيرس. هدفها هي تكون أبديت عن كل شيء دا يصير برا جديد من ناحية الأدوية، التشخيص، الأجهزة المتبعة، الطريقة اللي يستخدموها برا، وإن شاء الله تفيد. ليه احنا ندري العراق إنه آخر أبديت خاصة بالصحة هو من الثمانينات. فإن شاء الله يكون أطبائنا برا ودققنا وأكدنا أن يكونون عراقيين عندهم كامل المعلومات على المستوى الطبي بالعراق، وشلون تراجع وشنو يحتاج. فإن شاء الله تكون هاي الخدمة المقدمة تفيد، وأتمنى أسمع آراءكم بعد المحاضرة. شنو فائدتها، شو استفادتوا منها، شنو تتمنون مستقبلا يكون، لنغطي أكبر عدد من المعلومات ونحاول نتواصل ويا أكبر عدد من الدكاترة اللي يتطوعون ليوصلون هاي المعلومات للأطباء داخل العراق. وإن شاء الله تكون مفيدة. أنا ما بدي أطول على الدكتورة هند، وإن شاء الله تكون محاضرة ممتعة وذات فائدة. شكرا جزيلا للكل.
تفضلي دكتورة هند.
شكرا جميعا. صباح الخير. اليوم موضوعنا هو COPD Chronic Obstructive Pulmonary Disease. الصوت واضح؟
اي نعم واضح.
اوكي. So راح basically راح نمشي على ال principles ال basic science behind it, pathophysiology. هاي راح نمشي عليها سريع، وراح نركز أكثر شيء على ال newest guidelines for treatment.
دكتورة بس البرزنتيشن واقف يمي.
نعم.
البرزنتيشن واقف.
بعد ما حركته.
تمام.
أحب أوضح أنه first of all I have no disclosures. أنا ما أشتغل ويا ال Global Initiative for Chronic Obstructive Disease، ولا المحاضرة هذه هي تابعة للمستشفى مالتي، هي شغلي independent اليوم. التيبلز والجرافس أنا ماخذتها من موقع جولد اللي هو basically موقع عالمي موجودة به الجايد لاينز تتجدد سنة بسنة عن مرض COPD. وإذا تحبون تأخذون صورة للQR كود اللي على الشاشة راح ياخذكم مباشرة للموقع. So بنهاية المحاضرة هم راح نرجع نزور الموقع حتى أراويكم شلون تحصلون المصادر اللي استخدمتها هنا، لأنه أغلب السلايد شو مالتي أنا ماخذته من التكست بوك مال COPD. فكبداية the definition of COPD, chronic obstructive pulmonary disease, it's a common preventable treatable disease. حطيت هذه جواها خط because it's important to know that we can prevent it. It is common and deadly, but it is treatable. فلهالسبب early detection and early control of the disease has high yield. It is characterized by persistent respiratory symptoms. That's basically the definition. Mainly dyspnea or shortness of breath, cough and or sputum production. And airflow limitation that is due to airway and or alveolar abnormalities. So this means in COPD, damage can be to the airways alone or to the alveoli alone or both. When there's damage to the airways, that is the bronchitis element. When it's damage to alveoli, that is the emphysema component. And together they give us the COPD picture. Usually caused by exposure to any pollutants, really, most commonly tobacco smoking. بالعالم الغربي أول سبب لل COPD هو tobacco smoking. بالعراق بسبب التلوث المناخي والانفجارات والحروب ممكن أي أحد ياخذه من الجو، مو بالضرورة يكون شخص يدخن، بس مع ذلك smoking is still the number one cause. It's important to know that it may be punctuated by periods of acute worsening of respiratory symptoms called exacerbations. So just like any other chronic disease, it can go through exacerbations. Important to note that, like I said, بالعالم الغربي الملوثات الهواء تختلف عن العراق. Here we use النرجيلة a lot. كلش شائع استخدامها بين الشباب والشابات. فلهالسبب we don't think about it, but damage starts early بالعراقي population. Same thing goes للصوبات النفطية indoor heaters لأنه احتراق الكيروسين أو الفحم بداخل البيوت بدون تهوية ممكن يؤدي إلى نفس الأضرار و eventually COPD. So here are first.
دكتورة
تسمعوني؟
إذا ممكن بس شوية نوقف لأنه طفت الكهرباء.
أوكي.
تمام. نرجع ندوس HD. طفى مرة. ايه رادنا يا فيش. I think إنما 1 2 شوفه. تمام. دكتورة بعد شوية. الو.
تسمعيني؟
ايه تمام دكتورة. جت الوطني. بين ما اشتغلت جت الوطني.
اوكي بنرجع الصورة نكمل.
يلا دكتورة استمري.
Okay. So we were going over the causes of COPD. So we mentioned pollution, both outdoor and indoor pollution. It's important to know the genetic factors, especially alpha-1 antitrypsin deficiency. This is the most common inherited disorder in Western countries in Caucasian populations. مو شائع عندنا بس بالغرب جدا شائع. فلهالسبب هنا بأمريكا أي شخص يحصل الدياغنوسيس of COPD دائما يفحصون for alpha-1 antitrypsin deficiency. بالعراق this is not a common practice. Other risk factors: low birth weight, childhood respiratory infections, asthma, chronic bronchitis infections. This is to say that COPD can be present since childhood. There was, and we will go back, we'll go over that. So this is just to simplify the pathophysiology of it all. Basically, you will have some kind of pollutant. We're talking about cigarettes here, tobacco. These will release the reactive oxygen species, or as known as ROS. These reactive oxygen species will activate interleukin-8, leukotrienes, and tumor necrosis factor. The same thing nicotine will do, which will lead to extravasation of neutrophils. So neutrophils will release their granules, releasing further enzymes that cause direct tissue damage, or they will recruit macrophages and cause further tissue damage and emphysema. This is grossly the mechanism of acquired COPD, congenital alpha-1 antitrypsin deficiency will just allow neutrophil elastase to increase and cause further tissue damage by just consuming all the mucus and protective mucosa. Any questions about the pathophysiology?
أي سؤال عندكم؟ حاليا لهنا أكو سؤال؟ أي شيء؟ تمام دكتورة. أحد يسأل؟
So, risk factors, age, obviously older people are more likely to get it. Females are more likely to develop COPD than males, and socioeconomic status. This means people who live in areas of poverty where they rely on indoor kerosene heaters or coal, or use coal stove for cooking, that will contribute more to COPD. Plus, they are more likely to have children with low birth weight, and that will put them at increased risk of COPD. So this just shows that, like I said, not everyone is born with 100% pulmonary function. So this axis is basically pulmonary function, and this axis is age in years. Initially, the theory was that everyone is born with 100% lung function and it declines over the years. That's not true. People are born with different degrees of lung function, and once they develop COPD, their lung function will decrease significantly regardless of where they start. So if you do not have COPD, your lung function will decline from 100% to 71% at the age of 70. But if you develop COPD, you will go down significantly. You will hit 40%, close to 40% of your lung volumes. There's a graph similar to it that shows people who stop smoking tobacco, their lung function will not necessarily get better, but it will just stop declining. They will have the same decline as someone who has not smoked. So diagnosis, always suspected in any patient with dyspnea, chronic cough, or sputum production. If they have a history of recurrent respiratory illnesses, or a history of exposure to risk factors for the disease, such as chronic pollution or chronic smoking. So basically يجي أحد للعيادة ودائما عنده كحة، دائما عنده بلغم، الشخص إنه ما يقدر يمشي مسافة بدون ما يكون short of breath، أو a common complaint would be leg swelling، يجون إنه رجيناتهم مورمة. Just keep in the back of your mind, get a good history and suspect COPD. After getting a good history, the gold standard is spirometry, PFT, to diagnose COPD, basically post-bronchodilator FEV1 over FVC ratio of less than 70%. The WHO recommends that all patients with a diagnosis of COPD screened once for alpha-1 antitrypsin deficiency. Just worth mentioning that only 30% of patients with a clinical diagnosis of COPD have PFT documenting the disease. Do you know بين الحضور تعرفون من بين الpatients اللي diagnosed with congestive heart failure شقد نسبة من عندهم يحصلون الدايجنوسيس عن طريق الإيكو؟
دكتورة ممكن تعيدين السؤال؟
So مقارنة بالCOPD، إذا نعتبر الCOPD مرض مزمن مثل congestive heart failure، شنو نسبة المرضى اللي حصلون الدايجنوسيس عن طريق الإيكو؟ when we suspect heart failure, we send them to get an echo right away, صح? So 70 to 80% of patients with suspected heart failure will undergo echo, but only 30% of patients with suspected COPD will get pulmonary function testing. Basically بالنسبة لنا أي أحد يجي يقول أنا أدخن وعندي كحة راح نقول خلاص هذا COPD بدون ما نسوي الفحص الرسمي اللي هو pulmonary function test. And that is wrong. We underdiagnose. We overdiagnose clinically and undertest. Therefore, as feasible, يعني ما أعرف شنو الريسورسز بالضبط مال المستشفى. بس قدر الإمكان نستخدم ال Spirometry pulmonary function testing for documenting the disease. So this is the Spirometry. Basically, we close the patient's nose. They blow into a spirometer. The results will show on the screen. The numbers that we use mostly are FVC, which is functional vital capacity, and FEV1, which is forced expiratory volume. The magic number here for both of them is 80%. This means that of your lung, of whatever you inhale, you should be able to exhale 80% of it. If you are not exhaling 80% of the air in your lungs, this means that you're trapping air, and that's the definition of COPD, air trapping disease. So normal is equal or greater than 80%. Abnormal is anything less than that, with severe defined as less than 60%. Same thing for the ratio. This is roughly a description of a normal person's lung volumes versus a person with COPD. In a normal person with lung volume, the residual volume is less than 25%. This is the volume of the lung that has air we're not moving. In someone with COPD, their residual volume is more than 50%. So they're like a balloon. They are filled with air and they cannot get more air in. That's why they feel short of breath. بس تخيلوا أنه تاخذون نفس عميق ونحبس نفسنا وراح نحاول نتنفس فوق هذا النفس العميق اللي أخذناه بدون أي زفير. بس هذا إحساس المريض صاحب السي او بي دي، مثل النفاخة المليانة ولسه يحاول ياخذ شهيق وزفير ويا filled lungs. I love this graph because this shows basically what a normal lung looks at rest. Like we said, little residual volume. This is a COPD lung at rest. And the more they move, the more they increase their residual volume because their tidal volumes are getting smaller and smaller. Their inspiratory capacity is getting smaller. This is why they have lower exercise tolerance, and the worse their disease is, the worse their shortness of breath. Additional investigations, basically they're not all very useful. You just want to make sure to rule out other problems. So if somebody comes in with shortness of breath, you want to get a chest x-ray to make sure that they don't have pneumonia. You want to get a CT scan to look for bronchiectasis or for pulmonary embolism. What's important here is the pulse oximetry. We want to make sure that they are getting enough oxygen, and blood gas analysis, ABG, to make sure that, to decide whether or not they are retaining CO2. Exercise testing, not so common, but we do it. Laboratory testing, we check for eosinophil count because studies have shown that patients with higher level of eosinophils at baseline are at risk of developing COPD. Differential diagnosis, like I said, always keep in the back of your mind asthma, congestive heart failure, bronchiectasis, tuberculosis. All of these present with shortness of breath. Once we rule out these diseases, we can make the diagnosis of COPD and send the patient to get pulmonary function testing. Worth mentioning that patients can have these illnesses and COPD. So you can have asthma plus COPD. You could have congestive heart failure and COPD, and they will exacerbate each other. So never rule it out. So now we're going to go over the GOLD classification, which is the website I am quoting. This is from the GOLD criteria of 2020. Luckily نزلت كرايتيريا جديدة هاي السنة شهر 1 2023. راح نقراها بالسلايدات الجاية. هذا الكلاسيفيكيشن مهم حتى لما أحد يقول جولد 1 نفهم إنه ال pulmonary function testing مالتهم was normal. بينما إذا يجينا patient والريبورت مالته يقول جولد 4, this is very severe. This patient has less than 30% lung function, okay? So they go 1 through 4, and this is important to mention because this will determine how you treat it. GOLD 1 receives different treatment from GOLD 2, 3, and 4. It's not enough to only use pulmonary function testing to classify the types of COPD. We also use symptoms. So there is the modified MRC dyspnea scale versus the CAT assessment. This is the modified MRC dyspnea scale. Basically, you ask the patient to answer these questions regarding their shortness of breath. Okay. Grade 0 means I only get breathless with strenuous exercise, which is mainly most people. صح احنا كلنا لما نسوي تمارين high intensity كلنا يروح نفسنا. بينما modified MRC grade 1 هي shortness of breath when walking fast or going up a hill. Grade 2, they will say, I walk slower than people. يجي المريض يقول أنه ما أقدر ألحق، إنهم من نطلع نمشي للسوق أنا دائما دا أحاول ألحق بهم وما أقدر. Grade 3, I stop for a breath after walking about 100 meters. يعني على مود مثلا يقوم من المطبخ يروح للحديقة لازم يوقف ويجر نفس، اللي هو هذا شيء مو طبيعي. Grade 4, I am too breathless to leave the house. أصلاً يخاف يتحرك، يخافون يقومون من القنفة للحمام. Patients will mention that راح يقولون دكتور ما أقدر أروح للحمام لأنه بس يقوم حتى يتحرك get short of breath. That makes it grade 4. This is the CAT assessment. We use it a lot here in our clinics. This is a questionnaire for the patients. It's more complicated. It's a scoring system. So I prefer this one better because it kind of grossly tells you how the patient functionally is doing. This here just basically says, it talks about energy levels from 0 to 5, sleep quality, confidence in leaving the home, etc. And you get a total score here. So why is this important? Again, because it decides how we treat the patients. Based on the grade and based on the symptoms, they will fall into the A, B, C, D category. Now, this assessment tool is old. This is last year's assessment tool. The new one that was released this month, this is the most recent classification and treatment guidelines. Basically, this tells us, great, we use the GOLD 1 through 4, and we use the modified MRC criteria, which are 0 to 1 or more than 2. If you remember here, each one of these is a grade, so that is 1 through 4. And if you check 4, your score will be higher. You will fall into this category. Category E is people who have exacerbations. So all of these are people who are short of breath at baseline. A and B are people who are short at baseline, short of breath at baseline. E is if you have 2 or more exacerbations. So basically, يجينا مريض يقول كل سنة مرتين أدخل للمستشفى بسبب السي او بي دي، والpulmonary function test مالته يطلع لنا FEV1 30 to 50%. هذا الشخص classification مالته هو E3, gold E3. Okay, this will determine treatment, what we choose for their treatment. So these are the guidelines for assessing an initial diagnosis, initial treatment of COPD. Step 1, obviously symptoms, risk factors, and we will do spirometry like we said. We will decide on their GOLD criteria and classification, ABE, and exacerbation history, smoking status, comorbidities, etc. Just get the full story, full assessment. Initial management, if you see number 1 in the management of COPD is smoking cessation. Number 2 is vaccination, active lifestyle. Then we start pharmacological therapy. البيشنت ابو COPD اذا ما يبطل يدخن ويحافظ على نفسه من الامراض ما راح ينفع الادويه. نقدر نعطيه inhalers ونقدر نعطيهم ستيرويدز. عادي ندز وياهم علاقه من الادويه للبيئه، بس ما راح ينفع اذا هم راح يرجعون ويبقون يدخنون، لو يبقون يشتغلون بالمصنع ويتنفسون كل هذا الدخان. vaccinations كلش مهمة لأنه تمنع الإكزاسربيشن. ممكن يكون الشخص بطل تدخين وياخذ الانهيلرز مالته ويسوي الإكسرسايزز مالته بس ما ياخذ الفاكسينيشنز. ممكن تصير عنده إنفلونزا ويدخل بها المستشفى for exacerbation. COVID is a very common cause of COPD exacerbations now. So everyone should get their COVID vaccine, pneumonia vaccine, tetanus, and the flu. So after stopping the cause of the disease and preventing further exacerbations, then we start pharmacotherapy, which we will go over, and then we will manage comorbidities such as high weight, heart failure, etc. During the follow-up, so this is initial management. This is the first visit. During the follow-up, you want to reassess what you talked about. So the symptoms, the chart of the symptoms needs to be done at every visit. So PFTs will use them for the diagnosis, but this chart we will use every time they come in to see where they are. لأنه ممكن الشخص بأول زيارة يكون grade 3 ما يقدر يمشي مسافة. ورا استخدام الأدوية ممكن يكون grade 1. فهذا تحسن، أو يجي وبعده grade 3 فنحاول نفهم ليش لسه المريض grade 3، نحتاج نعدل الأدوية أو يجوز التكنيك مال الانهيلر غلط. هواية مرضى صعب عليهم يفهمون شلون يستخدمون الانهيلر. مهم كلش إنه نعيد هذا الأسسمنت بكل زيارة، نشوف ال severity of the disease and we assess وين الخلل بالعلاج. مهم لما نبدي أحد على inhaler is to test their inhaler technique at the clinic. قبل ما يطلع من العيادة تقول له استخدم البخاخ قدامي. If they demonstrate the right technique, that's perfect. And you have to check on that at every visit because you would be surprised at the number of people who do not know how to use their inhalers. Or even if you teach them, they forget. هواية من ال COPD patients are just old. كبار بالعمر يرجعون للبيت وينسون شلون يستخدمون. So تشيك بكل زيارة. Okay, so these are our goals. Our goals basically are to reduce symptoms, لما تصير symptoms, improve lifestyle, and then to prevent disease progression, which is high risk for mortality. So you want to yeah, you want to improve their life quality, and you also want to make sure that they don't end up very sick in the hospital. Now we're back to this chart with the treatment. This is a very important picture. It says here, initial pharmacological treatment. You remember, group A are the ones that have mild symptoms and are, regardless of their pulmonary function test. So if they have mild symptoms and no exacerbations, then we can just give them a bronchodilator. That's easy. This can be any form of short-acting bronchodilator or just a single long-acting bronchodilator. Group B are the ones that are more symptomatic. They're modified MRC rate than 2. These ones will need a combination therapy.
استمري بين ما يشتغل الشاشة عادي.
Okay. So patients with more symptoms will need combination therapy. So they will need a long-acting beta agonist and long-acting muscarinic agonist, antimuscarinic. Group E, they will need both plus inhaled corticosteroids. And group E are the ones that have exacerbations. Just remember E for exacerbation. These are the groups of medications. عندنا صورة.
ترى هاي المعاناة مالتنا تشوفيها. استمري دكتورة. سوري.
اوكي لا عادي. اوكي نرجع للأدوية اللي عندنا for COPD. Number 1 choice is beta agonists, specifically selective beta 2 receptor agonists, which are either short-acting or long-acting. Short-acting, such as phenoterol, there are many names. It doesn't matter. Albuterol is the most common one that we use. Long-acting ones, salmeterol is the one we commonly use, but all patients with COPD will need a beta agonist. Long-acting, the duration is 12 hours to 24 hours. So some of them, they only need to take once or twice a day. The short-acting is more of a rescue inhaler that they need to take every 4 hours or every 6 hours. The other group is anticholinergic, more commonly ipratropium bromide, the short-acting anticholinergic. And there is the long-acting anticholinergic. We don't use these a lot. We use the tiotropium maybe, but mostly we add ipratropium to inhalers. So the combinations are the common ones. It doesn't matter if it's short-acting, long-acting. It depends on how your patient is doing, what is accessible. Inhaler availability varies from one region to another. I want to mention here that methylxanthines are no longer used. I know historically we used theophylline a lot in COPD. This is no longer recommended because they carry a lot of side effects. So nobody uses theophylline. Try to always use the combination of beta agonist plus anticholinergic. If the patient is having more exacerbations, then add inhaled corticosteroids. Commonly formoterol and budesonide, salmeterol, fluticasone. These are very common combinations that work very well for COPD patients. Mucolytics are an option in patients who produce a lot of mucus, but the bronchodilators are more important. So that is the bronchodilator part of COPD, the common inhalers. There are other anti-inflammatory therapies such as inhaled corticosteroids versus oral corticosteroids. The use of corticosteroids in COPD has shown to slow the progression of lung damage. There are prostaglandin E inhibitors that are also shown to improve lung function, reduce moderate and severe exacerbation. Antibiotics, we use antibiotics for both treatment of exacerbation and for maintenance. So very commonly here in patients who have severe recurrent exacerbations, we put them on azithromycin either daily or 3 days a week. We see that a lot in patients with recurrent episodes. Okay, so moving on to key points of inhalers. Like we said, the choice of inhaler can be tailored according to the patient, availability, the cost, and always check inhaler technique. I cannot emphasize this enough. All right, so that was chronic COPD. That was basically just stable symptomatic COPD and the inhalers we use for it. COPD exacerbation is defined as episodes of worsening symptoms leading to substantial morbidity and mortality. COPD exacerbations are associated with increased airway and systemic inflammation and physiological changes, especially the development of hyperinflation. معناها المريض اللي عنده COPD at baseline ويوميا عنده قحة وبلغم الصبح ومتعود عليه، فجأة بدأ البلغم يزيد، بدأ يتغير لونه، وبدأت القحة تصير أسوأ. هاي exacerbation. هسه البيشنت تتحول من COPD مزمن إلى worsening respiratory function وممكن يحتاج يدخل للمستشفى. فواحدة من الأوراق اللي وزعتها هي how to triage patients with COPD. You want to assess a couple of things to decide. Do I treat this one إنه بس أقعده بالعيادة وأنطيه أدوية وأدزه للبيت، أو هذا شخص يحتاج أكسجين ويجوز همين ventilator فلازم أدزه للمستشفى. Cardinal symptoms, like I said, increased dyspnea, increased sputum volume, and increased sputum purulence. They're classified according to severity. Mild is one we treat with short-acting bronchodilators only, the LABA or LAMA, SABA or SAMA. Moderate, they are treated with short-acting bronchodilators and corticosteroids plus minus antibiotics. Severe exacerbations, patients will need to be hospitalized, and often their presentation is associated with respiratory failure. So once you identify signs and symptoms of respiratory failure in your patient, they have to be admitted to the hospital. Mild and moderate can be treated as outpatient. اكتب لهم bronchodilator, اكتب لهم steroid, أنطيهم antibiotics, وقول لهم كملوا الكورس 5 أيام وارجعوا لي بالعيادة. Severe, then قبل للمستشفى. The classification of severity شنو معناها لما أقول severe COPD, respiratory failure. So no respiratory failure الشخص الطبيعي respiratory rate is 25 less than 25 breaths per minute. Heart rate is that less than 95 beats per minute. If they develop hypoxemia, it is usually improved with supplemental oxygen with a minimum concentration with no CO2 retention on their blood gas. Acute respiratory failure, which is non-life-threatening, means tachypnea. They will have respiratory rate more than 25 breaths per minute. They will use accessory respiratory muscles, such as the sternocleidomastoids or the intercostal muscles. And you will see that their hypoxemia, their blood oxygen level will be low, but it improves with higher concentrations of oxygen. They don't get better quickly, they just need more oxygen. And they will start to retain CO2, causing PaCO2 to be between 50 and 60%. That's the definition of respiratory failure. Severe respiratory failure that is life-threatening is tachypnea, accessory muscle use, changes in mental status. If your patient becomes drowsy, somnolent, this means that they are hypoxemic and they are retaining CO2, causing acidosis, and this is what causes the patient to be somnolent. So دائما إذا الشخص أول ما يدخل short of breath عنده dyspnea وقلنا هذا COPD exacerbation فجأة تجي الممرضة تقول لك دكتور المريض بدأ أشو نعسان أو أهل المريض يقولون أشو ما يجاوب عدل. When you notice confusion or any change in mental status, this patient will likely need aggressive forms of oxygen supplement or even intubation and ventilation. So with that being said, I will show you the other slideshow that I'm using. Again, you can scan this barcode and it will take you to a great teaching tool that we will use now for tackling exacerbations. This is the website. This is what it looks like. It is the Global Initiative for Chronic Obstructive Lung Disease, which means it's abbreviated for GOLD. So this tells you what GOLD is, what they do, and then you can go down to the GOLD reports. This is renewed almost annually. And there is the full report that you can download and use. There is the pocket guide, which is the abbreviated version that you can download and use. And there is the teaching slide set, which if you want to present a lecture on COPD, you can use this slide set. These are all free to download and you don't need to make an account. Just click download and it will save. All right, so moving on to the teaching slides that I told you about, we will begin here. So this is what we were talking about, the difference between treating someone with just short of breath or someone with an exacerbation. So dyspnea, depending on their level of symptoms, we will give them long-acting beta agonist or long-acting anticholinergic. If they don't respond, we will combine the two. And if they don't respond, we will change and add steroid. In exacerbations, this is determined by blood eosinophil count. So if they have a high eosinophil count, you always add inhaled corticosteroids, regardless of the severity of symptoms. If their eosinophils are within normal limit, then we keep the combined therapy of beta agonist and anticholinergic. If no response, you add azithromycin antibiotic for no more than 5 days. So both the steroids and the antibiotics should be no more than 5 days. However, the inhalers will probably be lifelong. It's worth mentioning to the patients that their inhalers will be taking daily to prevent disease. معناها مو بس من تصير الاكساسربيشن نقول للمريض ياخذ الانهيلر، حتى لما تروح الاكساسربيشن لازم ياخذ الانهيلر مالته يوميا. حالة حال أدوية الضغط، حالة حال أدوية السكر، مجرد إنه ما يحس روحه عنده أعراض المرض مو معناها المرض راح. Okay, so non-pharmacologic management of COPD, number one, we are back to this, بس حتى أكد عليها, smoking cessation. They must stop smoking, they must stay physically active, and they must have these vaccines. Flu vaccine, pneumonia vaccine, pertussis vaccine, COVID vaccine, and shingles. I don't know إذا إحنا بلشنا نسوي الشينجلز فاكسين بالعراق أو لا للكبار بالعمر، بس على الأقل أول 4. So if response to initial treatment, we will just maintain the same thing. If they are comfortable with their inhaler, we will continue and just see them once a year. Make sure they are getting their vaccines. If they're not improving, then we will need to add further medications and see them more closely. This is another modality of treatment. So we talked about pharmacological therapy. We talked about inhalers, antibiotics, now oxygen, supplemental oxygen. This is not easy بالعراق. مو الحصول على الأكسجين بالبيت صعب. واللي أصعب من عنده هو إنه لازم نفهم المريض لما يحصل قنينة أكسجين بالبيت ما يقدر بعد يدخن، لأنه الأكسجين هي مادة كلش عالية الاشتعال والقنينة ممكن تنفجر. فأهم شيء نقوله للمريض لما يرجع للبيت وماخذ وياه قنينة أكسجين إنه إذا دخن بالبيت راح ينفجر البيت. This is very important إنه يبطلون يدخنون. The qualifications for our people who benefit the most from oxygen therapy at home are people whose baseline oxygen saturations are less than 88%. If they only desaturate at rest, they don't really need oxygen at home, unless their PaO2 levels are low. But generally speaking, only people who desaturate at rest have shown to benefit from receiving supplemental oxygen at home. And the goal is to maintain their oxygen saturation over 90%. They don't have to be saturating 100% at all time, as long as their pulse oximetry reads 90% or more. After oxygen therapy and pharmacological therapy, we will talk about surgical interventions. Here we do these often, which is just either bulectomy, you remove the area that has emphysema, or you put in a valve that kind of blocks out the area of damage, or in severe cases that are not candidates for minimally invasive procedures or surgeries, they will get a lung transplant. This is very rare. We don't really practice it for severe COPD. And usually when they reach the point where they need lung transplant, it's probably terminal and they don't often make it. Okay, so key points. I feel like I'm harping on this a little too much, but just smoking cessation, vaccination, nutrition, and good quality of life. Confounders or contributors to be considered in patients who are presenting with suspected COPD exacerbation is a pneumonia. Just because a patient has COPD and they present with purulent sputum, it's not necessarily a COPD exacerbation. It could be just a bacterial pneumonia. or it could be a pulmonary embolism that is worsening their shortness of breath, heart failure. So just keep an open mind and a high level of suspicion for COPD exacerbation, plus other differentials to avoid anchoring and medical errors. Okay. Diagnosis and assessment for COPD exacerbation. We talked about the severity of symptoms, the signs, and to evaluate using additional investigations such as pulse oximetry, lab assessments, mainly arterial blood gases, and to establish the cause of the event. So if you can send blood cultures to see if they have bacteremia, we can ask them if they have been in contact with sick people. So commonly هسه اللي نشوفه بالمستشفيات إنه الأشخاص يدخلون COPD exacerbation بسبب كوفيد، وراح يقولوا لكم إنه أي شخص بالعائلة كان عنده كوفيد أو كنت بعرس وكان أكو أحد مريض. COPD exacerbation is also common in people who have children، خصوصاً اللي يروحون الحضانة. لأنه الحضانة ما يروحون الحضانة يجيبون هواية أمراض وياهم. فإذا الأطفال إنه مثلاً عايشين ويا بيبيتهم وبيبيتهم عندها COPD، يجون شايلين الجراثيم مالتهم من المدرسة و it ends up causing a COPD exacerbation. So مهم نسألهم sick exposure ومهم نسألهم if they have exposure to children that go to daycare. This is a really nice algorithm for treatment. إذا ما تقدرون تتذكرون كل اللي فات من المحاضرة بس أخذوا صورة لهذه واستخدموها. This is a good summary of what we talked about. The differential diagnosis, what to keep in your mind, and the classification of the severity of the illness. Mild COPD, patients are basically just short of breath. Moderate COPD, they are short of breath and they have abnormal ABG. They will have CO2 retention. Severe COPD exacerbation, they will be short of breath, abnormal ABG, and mental status changes. They will be somnolent. So this takes us to the indication for hospitalizations, which are basically any severe symptom. If they check any of the boxes here, they need to be in the hospital. Okay, so here we go. This is kind of a review. Treatment of a COPD exacerbation is kind of similar to basic management of severe COPD, except that you're going to be more aggressive with bronchodilators. You will, if they are already on it, you increase the dose, you increase the frequency. فمثلا إذا شخص كان ياخذ ابراتروبيوم كل 6 ساعات باليوم، تسويها كل 4 ساعات. إذا كانوا ياخذون بس beta agonist، تزيد فوقها inhaled corticosteroids or anticholinergic. So we just escalate the treatment. We start oral corticosteroids if the patient is drowsy and they cannot take anything orally. We will give them intravenous corticosteroids. Usually what we use here is Solimedrol. We will use 125 milligrams IV on the first day of presentation. Then we start prednisone taper. Depending on the severity and frequency of exacerbation, prednisone is either a 5-day course, no taper, or for recurrent exacerbations, we do a long taper. So key points here, short-acting beta agonist with or without short-acting anticholinergics are recommended as the initial bronchodilators to treat acute exacerbation. Systemic corticosteroids can improve lung function. And again, they should not be used more than 5 days. المرات الوحيدة اللي نزيد بيها كم عدد الأيام اللي الشخص ياخذ بها الستيرويد هو لما يكون عندهم عدة exacerbations. بالسنة الواحدة أكثر من 2 episodes is too many recurrent episodes ولازم نزيد ال duration of steroids. Methylxanthines against theophylline, they are not recommended anymore. And something to keep in mind is non-invasive mechanical ventilation should be the first mode of ventilation. This is not readily available بالعراق بس بأمريكا نستخدمه هواية CPAP و BiPAP, which is kind of, it provides positive pressure ventilation without the breathing tube. So it is a non-invasive positive pressure ventilation. These are the indications for admission to the intensive care unit. So this is another step to triaging the patients. أول ما إجا المريض وال COPD exacerbation أول قرار لازم نتخذه هو أنطي أدوية وأدزها للبيت لو أدزها للطوارئ. ورا ما دخل بالطوارئ القرار الثاني اللي لازم نتخذه هو أدزها للردها لو أدزها ICU أو RCU. These are the criteria for going into the RCU. Persistent or worsening hypoxemia, changes in mental status, or they're just not responding to treatment. You're giving them treatment, but they keep getting worse. خلاص دزهم للICU. This is the same thing, indication for positive ventilation. And these are the indications for invasive mechanical ventilation, intubation, which are basically the same indications for any patient that needs intubation. They cannot, they have massive aspiration or they cannot remove their secretions. They are hemodynamically unstable, etc. After discharge, once your patient is stabilized and you send them home, it is recommended that you review all of their labs and all of their medication list. Double check with them that they're using their inhalers correct, and try to see them within 1 to 4 weeks after their discharge. If they are getting better, you can check with them annually. If they're not getting better, you have to see them at the 12-week point. So أول ما يطلع من المستشفى نشوفهم بأول شهر وراح نشوفهم مرة ثانية بعد 3 أشهر. This is a summary that I like to keep. You can take a picture of this too. Basically, it just says the main categories of treatment and what we use, and we usually use these combined. We don't use the roflumilast very often, but definitely vaccines and inhalers. Here in this slideshow, they touch on risk factors for development of lung cancer. This is not a COPD topic per se, but most COPDers are at very high risk of developing lung cancer because they're usually smokers. So anybody that has been smoking more than 30 pack here needs to start receiving low dose CT scan for lung cancer screening annually. This is not a practice that we do بالعراق. That's unusual for us. Okay, just something to keep in mind that we are still in a pandemic. COVID is still very rampant. So patients who with COPD need to be advised to always take their boosters and to always wear a face mask. I know صعب هسه ورا كل هاي السنين تعبنا من كوفيد وما نريد نلبس الماسك، بس لازم نفهم المريض اللي عنده COPD إنه هم مناعتهم غير شكل، هم كبيس لاين عندهم ضرر بالرئة، وأي فيروس يدخلهم خصوصا كوفيد ممكن يقتلهم، فلهالسبب ننصحهم بالإضافة إلى عدم التدخين والفاكسينز، اللقاحات مالتهم لازم يلبسون الماسك. كسمري للمحاضرة اليوم، راح أعيد وأسقل بس smoking cessation أو السجاير، هاي أول نصيحة نقولها للمرضى. E-cigarettes are not, I mean, the effectiveness and safety of them are uncertain. فإذا المريض يقول أنا ما أدخن بس أدخن فيب، ما نعرف شنو الضرر مالتها، بس يعني حاليا it does not show that it's beneficial. We do pharmacological therapy. It reduces exacerbations and symptoms. Inhaler technique, always check with your patient whether they're using the inhaler correct. Influenza, COVID-19, and pneumococcal vaccines are necessary. Long-term oxygen therapy in certain population of patients, and there are also surgical options for COPD. Any questions?
هل عندك سؤال؟ كان عندك سؤال دكتور شيء؟
يعني الكورتيكوستيرويد
بس علي صوتك كي تسمعك.
بالنسبة للكورتيكوستيرويد انهيلر بس الكورتيكوستيرويد
دكتور السؤال
سيستميك ديزيز
دكتور سمعت السؤال؟
اي عادة نسوي عادة بس corticosteroids، يعني هو السؤال corticosteroids versus other kinds of steroids like mineralocorticoids لو السيستميك افكت مالتها. Basically to combat the inflammation، لأنه they work by reducing the neutrophil effect، لأنه اللي تسويه corticosteroids تبقي neutrophils intravascularly. So when they remain intravascular ما راح يطلعون يوصلون لللنج تيشو، فراح يقل عندنا الانفلامatory response وراح يقل عندنا airway obstruction.
شكرا دكتورة. بعد من عنده سؤال تفضل، بس علي صوتك حتى تسمعك. أنا بدي أسمعك، علي صوتك. دكتورة تسمعين؟
لا يمكن لو تتقرب شوية على الميكروفون.
قرب بس قرب لنا شوية. أنا بدي أسمعك زين.
بس يعني السي او بي دي لازم أكسجين محدود، يعني مو حسب واحد احتياجه، مثلا يعني في الجول نخلي لحد 89 ايش يعني مو هنا.
صحيح يا هذا موضوع ما يتفقون عليه العالم، لأنه المسكونسبشن هو originally كان عبالنا إنه أي أحد عنده COPD هو الأكسجين ليفل مالته يكون أنصى من الشخص الطبيعي. الحين أكو هواية ليفلات من COPD. There's a spectrum. أكو ناس عندهم COPD بس الأكسجين ليفل مالتهم is normal، فلازم نبقي الأكسجين ليفل مالتهم عالي 95 وفوق. أكو ناس عندهم COPD بس دائما عندهم CO2 retention، فمتعودين عايشين بال ال 88 وال 89% oxygen levels. لهالسبب النصيحة حاليا الجايد لاينز هي to tailor التريتمنت، بدل ما نقول كل ال COPD patients نقلل الأكسجين تارجت مالتهم. حتى تشوف يا كاتيجوري المريض مالتك ندور على metabolic alkalosis، لأنه إذا عندنا CO2 retention فالشخص راح يكون عنده respiratory acidosis. compensation راح نشوف البايكارب level بالسيرم مرتفع، وهاي معناها أكو chronic compensation من الكدني للrespiratory acidosis. This person will be a chronic CO2 retainer، فعادي أخلي الأكسجين مالته 88. إذا شخص الكدنيز مالته مو بحالة compensation وما متعود على low oxygen levels، حتى بغض النظر عن السيفيريتي مال COPD مالته لازم يكون oxygen level مالته عالي.
دكتور
العفو. الاكسجين بالحاله الاكسسربيشن يعني احنا نعالج الجايد لاين مالته نخليه بين 88 الى 92 يعني مو اي بيشنت يعني سي او بي دي يعني لازم يعني نخليه 88 الى 92.
لا حتى إذا exacerbation مثل ما قلت لك يعتمد على المريض نفسه. إذا هم عندهم CO2 retention طول الوقت، فحتى بالexacerbation نبقي الأكسجين level 88 89 ممكن. بس إذا الشخص بالexacerbation وما عنده history of CO2 retention فلازم نبقي على الأقل 90 فوق.
اي اوكي، بس السيفير كيس هو ماي كيس يعني اذا بيشنت مثلا الاكسجين مالته مثلا 95 هو بيشنت يعني بالاكسسربيشن يعني مو كمان ننزل الاكسجين مالته ل 92 او
لا ما ننزله بس إذا
البيشنت اذا كان هايبوكسيا سيفير هايبوكسيا فنعطيه الاكسجين الليفل مالته نخليه بين 88 الى 92 يعني هذا الجايد لاين حتى يصير
بلي يا صحيح ما ننزلهم. إذا هم الليفل مالتهم مبقي بالتسعينات نعوفهم عادي.
زين دكتور، نفس البروتوكول المستخدم هنا مثل برا؟
احنا تقريبا نفس البروتوكول يعني مالتنا، يعني مثلا احنا اي بيشنت يجينا مثلا سي او بي دي اذا كان ستيبل بيشنت ستيبل سي او بي دي فاحنا نعطيه عاد مثل لو نمشي على الاف اي بي 1 مالته بوست برونكودايليتر. اذا كان يعني ستيج 1 نعطيه اونلي بس برونكودايليتر اونلي. اذا كان جريد 2 نعطيه برونكودايليتر and LABA. إذا not response to LABA and still FEV1 decrease نعطيه LABA and LAMA. إذا ظل FEV1 less than 50 صار 50 بس لازم نعطيه steroid. يصير LABA and LAMA and corticosteroid.
تمام، شكرا دكتور.
يعني تقريبا هو
نفس الشيء.
تقريبا احنا نفس البرنامج
بالضبط. الجريدنج ما تغير، بس هسه هواية يمارسون العلاج بيست على السيمتومز مال الشخص. فبالإضافة إلى الجريدنج 1 through 4 نعتمد على الكويستشنير مالتهم. فإذا patient الجريدنج مالته 1 أو grade 2 فهو مو سيفير صح، فبس راح نعطي لاما أو لابا. بس يقول لك ما أقدر أمشي منا لهنا، فهذا الشخص راح يحصل تريتمنت أكثر لأنه we treat symptomatically as well.
هو الجريد هو اوريدي راح ينكريز عن الجريد اوريدي. بيشنت هو شفتي جريد 1 او جريد 2 بس البيشنت نوت ريسبونس مثلا لابا ولا ما اكيد راح نعتبره جريد 3 وراح نزيد التريتمنت عليه.
No, so الجريدز ما تعتمد على الريسبونس للتريتمنت. الجريدز تعتمد على ال FEV1 result. So that is fixed. من البيشنت يسوي البulmonary function test مالته الجريد مالته is fixed. التغيير بالعدد الأدوية اللي يحصلها يعتمد على ال symptom severity will response to the treatment.
أحد عنده سؤال؟ أي سؤال يخطر ببالكم؟ تمام دكتورة، احنا كلش نشكرك، عاشت ايدك عن
شكرا جزيلا،
وان شاء الله استفادوا يعني، او خلينا نقول اكو ابديت صار بالموضوع، وشكرا جزيلا لك وجهودك. تسلمين.
شكرا جزيلا.
ست زينة تحبين تقولين شيء قبل ما نختم؟
لا شكرا للكل، شكرا دكتورة هند، شكرا جزيلا. شكرا للدكاترة، وإن شاء الله إذا عندهم ملاحظات أو مواضيع ثانية يا ريت